We're viewing diabetes as an epidemic, which it is. Epidemic meaning a disease which has increased rapidly over a period of time. And that's what we have in diabetes. And if you look at the cover of the book, you'll see it illustrated very clearly. And what our approach has been is to think of it, if you're dealing with an epidemic, why don't we face up to it and treat it, manage it, as we would an epidemic of something else. Currently, I should back up and say, I've spent a lot of years doing cancer control. I came to Kentucky in 1983 to be the first director of the Markey Cancer Center at UK. Much of this time was spent in eastern Kentucky trying to deal with cancer control issues. As a consequence, I learned a little bit about the other health problems in eastern Kentucky. And you can't go very far without coming across diabetes as a major problem. And I'll talk a little bit later about complications. What we're going to talk about is how diabetes is not just a touch of sugar, which everybody talks about. And many people in eastern Kentucky will tell you right off, well, everybody in my family's got a touch of sugar. Nobody much wants to talk about the amputations of limbs, which is present, kidney failure, so that people are on dialysis, and complications of this kind. It's not an innocuous disease, diabetes. But I've come at it as one looking at it for almost the first time. It's not what I spent my career on. But we're committed to trying our best to do something about it because it's such a dreadful problem. I think I just saw yesterday or day before, diabetes is now in the world the 7th leading cause of death. People don't appreciate that as such. And part of the reason we don't appreciate that is because people with diabetes are blamed for their problem. If you had just eaten right, if you just exercised, you wouldn't have this problem and we wouldn't be in this fix. Well, blaming the victim hasn't gotten us very far, and it isn't going to improve the situation at all. So our suggested answer is that we need to look at it as an epidemic and deal with it as a community problem, not just a problem of each individual. So I'll come back to that. But to give you a picture of what diabetes is doing to us, and perhaps in Kentucky, Isaac was going to take over from there.
Now we're going to focus on type 2 diabetes, not type 1. In some ways, I think they're two very different diseases. And we're not really going to give a medical talk about the medical aspects of diabetes or a self-help how you can manage diabetes, but we're really going to talk about it as a broad-scale population problem. The recent study came out and said that 55% of people in California either had diabetes or pre-diabetes. That's just a tremendous amount of people who have that. Now we're going to talk about how common diabetes is, what the consequences are of it to society, and what can we do about it on a society level. Now, everybody has blood glucose. It's something important in terms of energy in the body, but at some point, some people's blood sugar begins to rise, the blood glucose begins to rise, and at a certain level, it reaches what they call pre-diabetes, which is where it's elevated but not at a dangerous level there. And really at that point, you have some opportunity to control it, to reduce your blood sugar back to normal level. When it reaches the diabetic level, it's very difficult to bring that down again. You'll see some books in the library saying you can do that, but the evidence I've seen has said you can't do that. And what happens is that the body is unable to produce either enough insulin or it has insulin, but it's not able to use it very effectively and stuff, so that the blood sugar does rise, and that additional blood sugar causes a lot of damage to your blood vessels, both the large vessels and the small vessels. And particularly, it will affect your heart. It will affect your eyes, a lot of blood vessels there. It will affect your kidneys, and it will affect your feet, well, as well as a lot of other parts of your body. But those are some of the main areas that it does affect. Now, there's a tremendous impact on society from diabetes, and it's really one of the drivers of your health insurance cost. And if you're looking at the increase of health insurance, diabetes is what's really causing that to increase. We talked to the head of the state's health plan for health employees and stuff, and he says clearly diabetes is driving the expenses for that. The paper we gave out says that $1 of every $5 for medical care is for diabetes. And a person who has diabetes, it costs their insurers from $8,000 to $10,000 more per person to care for that person than someone who doesn't have diabetes. And the New York Times had an article a few years ago saying that someone who has diabetes is going to pay out of their pocket about $6,000 a year. That includes their time cost for going to doctor's visits, but supplies, other things that they need. A number of things aren't covered and stuff, so it's an expensive disease for a lot of people. And employers pay a price for this. There's about $70 billion in this country that are lost productivity because of diabetes, and that's because people are not there at work, or they're at work and they're ill, or that they have morbidity, the complications from it, or they die early. So that really affects the economy an awful lot. Now in Kentucky, there are about 600,000 people who've been diagnosed, who have diabetes. Now about 25% of the people who have diabetes have not been diagnosed, and so they're probably not getting treatment, and they're down the road of the complications developing there. But about 600,000 people out of, I think, 3.5 million people in the state? 4 million people. And it's estimated about, now multiply 600,000 by $10,000 excess medical care cost. And that becomes a very large number, it's about $6 billion of excess cost just due to that one disease. And about 1,100,000 people have prediabetes. And among that number, about 90% of them do not know they have prediabetes. But these are based on some studies of populations, a number of people. So I'm going to give you some more bad news, and then I'll give you a little bit of good news about things. I like to say that diabetes is bad because it results in blindness, results in amputations, and it results in dialysis from kidney failure. In Kentucky, this year, there will be about 1,000 amputations as a result of diabetes, and that's about 3 a day. There's about 820 cases of renal failure, and statistics show about 72,000 people have some kind of visual impairment because of diabetes. A friend of mine works at the UK hospital emergency room, and a man came in there, and the doctor said to him, I need you to sign this release so I can amputate your toe. And the man says, no, you're not going to amputate my toe. And the doctor says, well, that's okay, but you will die from that. How long have you had diabetes? And the man had no idea that he had diabetes, and so had no idea that this complication was caused by that. And so many people do have a serious complication, and they go in and the doctor says, well, you have diabetes from this, and they don't know it. So that's part of the bad news there. There's some good news, though. The good news is that diabetes is really largely preventable. It's one disease that we really can prevent, and we know how to prevent it. Now, there's 2 main ways to prevent diabetes. The hard way is you lose weight and you exercise more. It's really hard for people to do that. But you only really have to lose about 7 to 10% of your body weight to make a huge impact on your health. And really only need to exercise about 3 hours a week. That can make a big difference in whether or not you get diabetes. And this has been proven through some studies that looked at whether or not an intervention like this would work. Now, there's an easy way that's not quite as effective, but is very easy, which is take a pill. And this pill has been around for an awfully long time, and it's extremely cheap. In some drugstore chains will offer it to their customers for free if you're a customer of them. So it's called metformin. And it's pretty effective in terms of reducing your blood sugar level. Now, if we can prevent diabetes and these bad complications, why is it that we don't do that? And there are a lot of barriers to things. You can talk about doing new stuff, but to me it's important to talk about what are the barriers that keep us from addressing this. Now, one is that it really has no symptoms, at least in the early stages. And so people don't see it as a problem. It's like blood pressure, high blood pressure. It doesn't really have any symptoms until you have some problems with it. And like I said, sometimes people are diagnosed by the time they wind up with a complication. And most people, like I said, with prediabetes do not know it. That's about 90% of those with prediabetes who have a really good opportunity to do something about it don't know it. Now, one of the reasons for that is that for a number of diseases like cholesterol and heart disease and blood pressure, we routinely screen for that. I'm sure all of you have had your blood pressure measured in the past year or so, but we don't really do routine screening to look for diabetes. And so that all these cases are out there that they don't know about it. The healthcare system doesn't know about it, and so we don't work to reduce their chances of getting diabetes. And if they have it, we don't make sure they're in good care so that the complications are less likely to occur. Another thing is that there's an awfully long lag time between the time that the disease begins and the time you see complications, and that could be a couple of decades on that. And in that time, you can often say, well, that's going to happen to somebody else. That's really not going to be my problem. I can kind of forget about it or worry about it later kind of things. So that's our psychology plays against us in that regard. And it's so easy to think, well, diabetes is not a big deal and those bad complications are really going to occur to someone else and not occur to me. Now, I mentioned that screening is very effective and prevention is very effective. Some interventions for changing your lifestyle can cost maybe $500 or maybe a little bit more. And they have been found to be pretty effective in either reducing your chances of getting diabetes or delaying that. But what happens is that you've got to pay money up front to get that benefit down the road. So you may pay $500 up front, but you'll only have the savings of $10,000 per person down the road. Now, I don't think I would see Governor Bevin on TV saying, I want to spend $500 for these 600,000 people in the state. Spend that money today so that we can save $10,000 in 15 years from now. I just don't see that happening. So that there's that part of our political system doesn't want to deal with that. And like Gil said, we want to blame the victim. I don't know if you remember a few years ago that Paula Deen came out and said she had diabetes. Well, people jumped on her and says, well, that's because you like butter so much. And so they're really blaming the victim for that. I don't think that human nature has changed an awful lot over the past many generations, but now you're seeing a whole lot more diabetes. So what really is happening is that the environment that we live in has changed. I did a look about 6 months ago. I looked at the number of barbecue places in Kentucky, in Lexington, and I looked at Google Maps and I looked at all of them. And I've only been here about 8 years or so, and I noticed there are about 10 more barbecue places in town than there were about 8 years ago. So what was once a food that you ate uncommonly, maybe once a month or something like that, becomes something that you can eat every day. And so that our food environment has changed over time. But we blame the victim for these kind of things. So I've talked to you about the cost of diabetes and the cost of society and individuals and what a large problem it is. And there's some good news that we can do some things to address it, but there's some barriers that we have to face on that. So in our book, we talk about, well, how do we approach dealing with this really at a community level so that we can make a difference to it? And that's what Dr. Friedell will speak about.
When we got to thinking about the problem, actually it's been about 7 or 8 years when I realized that, I don't say this very often, but diabetes is a bigger problem than cancer. And it's the fact that it's preventable. Cancer might be, but I don't think so very easily. We got to thinking about it, and I began thinking about it in terms of what we were doing in eastern Kentucky to try to get more women screened, more men screened, to deal with prevention in the sense of cigarette smoking, to do what we could, but diabetes seemed to be something that was accepted. And the people that we got together to talk about cancer, I asked them about diabetes. Well, everybody in my family's got a touch of sugar. And that's just sort of accepted, as Isaac is saying. And we don't recognize the barriers that keep us from doing what we could do, what we should do. So what can we do about it? Well, our approach is to, first of all, recognize that we have an epidemic and that we speak about it as an epidemic and that we say to ourselves and to our friends, but let's deal with it as we would an epidemic. It's a non-infectious epidemic. And that takes away a little bit of the frightening part, that's just the words associated with epidemic. Usually people are frightened. You talk about the discussion we've been having about Ebola virus. And it's interesting that at the University of Kentucky Clinic, where I get my care, they've been distributing a piece of paper that says in bold letters, "Ask about Ebola." And now we're asking patients who come in if they've been overseas in the last 21 days. Well, that's fair enough. But why don't we have a sign on the back saying, ask people what their A1C number is? We had, in eastern Kentucky at one point, in Floyd County, we started talking about this, and one of the people who was involved with the Diabetes Coalition in Floyd County suggested we had to have a campaign in the community with big billboards. And the billboards would ask the question, what's your number? We haven't done that yet, but I think that's something like that which piques the interest of the public is something we haven't done, but we've done it for Ebola. So far, I think we've had 6 Ebola cases in this country, all coming from elsewhere. And so our focus, though, is on something that frightens us, and diabetes obviously doesn't. What are the things we can do? Well, if we're going to involve the community, then let's take a public health approach to diabetes. And if you're dealing with a public health problem, you want to know the size, the extent, the nature of the problem. Where is it? Who's affected? Who could be affected next? How do we get this approach over to a community? Well, let me start out by saying in Kentucky there's a really remarkable public health system. Every county has got a public health department. The basic structure is here, but it isn't being used for the purpose we're talking about. For the purpose we're talking about, you need total community awareness. Everybody has to know that diabetes is our problem, not individuals' problem, but it's our problem. As Isaac pointed out, the cost to the community is tremendous, is huge. The cost to employers is there. we have a problem which is very large. Why don't we acknowledge it and say this is a community problem and we are going to do something about it? We think that's step one. That has to happen. We also, if we look at where is the problem and who's involved, we have to be able to measure it. It's not loose talk that there's a lot of diabetes. That doesn't help much. How many people are involved? And where do they live? And how old are they? How long have they had diabetes? This kind of information is not available but should be. It's the kind of information that I helped to put together beginning in 1984 when I came to Kentucky. We set up a statewide cancer registry in which every case was reportable and confidential information was kept, but we know a lot about cancer in this state. We don't know the same kind of information about diabetes, and we should. So we think you have to have a community-based diabetes council, which has representation on it from all segments of the community, including business, education, and so forth. People have to be talking together about the diabetes problem. And we don't. We still think of it as an individual problem, and many people that I've found don't really want to talk about it as a public problem. It's a very private problem. That doesn't get us where we need to go. And then Isaac mentioned screening along the way. We're recommending in the book, you may or may not have seen it, that there ought to be universal screening. Nationally, people are saying there ought to be universal screening for people over the age of 40, because diabetes may not become evident until you're in 50s, but it starts when you're in your 40s. And the earlier that you start to manage it, the more likely you are to avoid complications, which is what we want to do. So we advise universal screening, and the American Diabetes Association has been strongly recommending that, and what they say is they address the public, and they say, go see your doctor, and your doctor will screen you for diabetes. People don't go to see their doctors. Doctors don't often screen for diabetes. They should, could, but it isn't being done. And so we have a way to go in finding out the dimensions of the problem with data, not guesswork. We should know everybody who's got diabetes, not to blame them, but to try and keep them from developing complications. And the earlier you start with that, the more likely you are to accomplish it, to avoid the problems that Isaac was just talking about. So we have to engage the community, and we think one way to do it is through the formation of a community-wide diabetes council with everybody represented, people who have diabetes, people who have pre-diabetes, people who don't. But everybody should know about it. Then those of you who have diabetes, I'm sure, are getting good care, and at some point you've gone to your physician, and your physician has taken over the care. But for many people, let me just speak in generalities. People go to their physician to find out they have diabetes, and the physician gives them some paper that tells them what to do and sends them off and says, come back in 3 months and let's see how you're doing. It isn't always easy for individuals who've been told they have diabetes to find out what they need to know and where they can get not just information, but advice and comment. we think this is an issue that has to be met, and we think there should be adjunct care, not to compete with physicians, but to amplify and extend the care that physicians are suggesting you get. We think there should be places in the community where diabetes self-management could be obtained, information and skills. These self-management centers should be in touch with their physicians, should be extensions of physicians' care, not competing. I emphasize that because I don't think it's always true, but it's said that the important thing that physicians want is to have their patients return to them if they go elsewhere. Great, let's do that. And there's no reason why there shouldn't be these care centers in communities. I think we also have to take a direct look at our care system. If you're going to provide adequate, comprehensive care to people with diabetes, you have to have the capabilities to do that. I'm not sure currently we have enough care providers who know enough about diabetes and complications to be able to really do something beneficial for their patients. I hope so, but I'm not sure. And if we don't, we should look at the system and see, do we need more people in the system? Do we need more dietitians, or do we need more individuals who are helpers of people to get them into care? We're trying some of that in Eastern Kentucky. We're doing a project that involves 5 counties in the Big Sandy district. And some of the people we're trying to get involved are helpers. They're not dietitians, but they know enough about the disease and the problems, and they deal with people directly. They're from the community, and they exemplify the community's responsibility in caring about diabetes. So these are things that we can do, but there's another group of things we can do. Isaac was describing what some people have called an obesogenic environment. You go into a restaurant and they serve you more than you actually need. Fast foods provide you more non-nutritious as well as nutritious calories than you need. There are things that we can do to change the environment to make it somewhat more healthy. And I would emphasize that this view of the environmental health impact is something we should be thinking about at a very early age. Our school kids ought to be the beneficiaries of education about proper diet. And they should learn about foods. It isn't that everybody hates broccoli. If kids are exposed to broccoli as well as other things at an early age, not forced to eat it, but just exposed to it, it turns out that they will accept it as they grow up, and broccoli is no longer disparaged by people. So collectively, we have to look at what we can do, and we have to think about it over a lifetime. Those of you who have diabetes are better aware than I don't have diabetes, better aware than I that we're talking about a lifelong issue, and that the earlier you start dealing with it, the more likely you are to be successful. And so I think it's important that we think about children and making them aware of the issues, and also trying to help them by guiding how they look at food, but also exercise. If you look at the schools, many schools have cut out recess or cut out exercise in order to do something else, something I'm sure as educators you'd think had to be done. But I think it's a loss. We probably just didn't have as many formal things when I was a kid. They just sort of turned us loose and then collected us again in school or after school. But now things are better organized. And so we don't have the level of exercise and focus on exercise that we used to have, and we miss it collectively. We need to do something about that. So what I've been talking about is that let's recognize the problem that we have. Let's recognize that we can do something about it. Let's agree and understand that we can prevent the development of type 2 diabetes and can do it better than we're doing it now.